Lecia Sequist from Massachusetts General Hospital. I wanted to spend 5 minutes talking to you about lung cancer screening and some of the updates in the field in 2020. So lung cancer screening has been proven to decrease lung cancer specific mortality as well as overall mortality. We've known this for almost 10 years since the NLST was published in the New England Journal back in 2011. But since that time, I would say we've done a really very poor job across the world in implementing lung cancer screening programs. There's been a lot of reasons, including barriers that have been put up in front of accessing the scans, as well as, I think a good amount of skepticism and nihilism about lung cancer in general and about the benefits of screening. In the US, specifically, CMS instituted some guidelines that made it necessary for patients to have a doctor's order. This isn't true for other screening studies such as mammograms, but you need to have a doctor's order to have a low-dose CT scan, and you also, in order to get reimbursed, need to have a documented shared decision-making visit, which was left a little bit open to interpretation. And I think that from a systematic point of view, many institutions had some concerns about what exactly constituted a shared decision-making, how to make sure it was documented in a way that that would be reimbursed. But despite some, early barriers that I've outlined, I think many institutions have really come on board with more excitement in recent years. And certainly screening seems to be slowly picking up. I'm hopeful that is really going to pick up to a much greater degree thanks to some exciting new data and new changes in the field in 2020. So first was the publication of the Nelson study. This is a confirmatory randomized trial showing indeed that lung cancer screening improves lung cancer specific mortality. The Nelson study was much smaller than NLST, only about 15,000 patients compared to 50,000, and so it was not powered or not able to show an overall survival benefit. But we did learn a lot of really interesting things from Nelson. And most importantly, that the longer you screen patients, perhaps the more benefit accrues. And I think this is really one of the shortcomings of the National Lung Screening Trial because it only screened people for 2 years. There was a baseline CT and then 2 follow-up CTs annually after that. The Nelson study followed patients and screened them for 5.5 years, and the benefit does seem to increase over time, which makes sense. Patients should really think of lung cancer screening as a program, not just a one-time test. It's those interval cancers that develop between the screening scans that, that's where we really have the most chance of helping change the natural history and save lives. So Nelson also suggested that there was potentially a larger impact of screening for women compared to men, although it was underpowered to really confirm this benefit because there were very few women enrolled in the Nelson study. It was predominantly a male study, yet it showed that the benefit may be even greater in women. This is something that was hinted at in the NLST results too, and so we need to further study any gender sex differences that exist in screening. Another really exciting advance that has happened just recently over the summer in 2020 is that the U.S. Preventative Services Task Force, the organization in the U.S. at least that sets the guidelines and determines the strength of the evidence for various screening modalities, has drafted a recommendation to broaden the criteria for lung cancer screening. So, one of the frustrating things about lung cancer screening as it stands is that it's fairly hard to get patients to qualify for screening. You have to be 55 years old, you have to have smoked 30 pack years and quit within the recent 15 years. And in fact, for patients that we see in the oncology clinic who walk through the doors with new advanced lung cancer, only a portion, a minority of them would have even qualified for lung cancer screening because the criteria are strict. But now the U.S. Preventive Services Task Force is proposing to lower the age of start of screening from 55 down to 50 and lower the required pack years from 30 pack years down to 20. This will help more people get their foot in the door for screening, and I think importantly it will really help equalize or strive towards better equity in lung cancer screening among racial groups. Black patients in particular tend to be diagnosed with lung cancer at an earlier age and potentially with less smoking history compared to their white counterparts, and so making these changes as the U.S. Preventive Services Task Force is proposing will help achieve a more equitable access to screening for all patients. I think moving forward, what we need is better information about how to find lung cancers and how to tell who's at risk in patients with even lower smoking, and also better implementation science to help us figure out how to execute lung cancer screening across the world in all different sorts of situations, resource-rich and resource-poor settings. Lung cancer screening does pick up a lot of nodules which aren't cancer, and so having the clinical expertise to triage appropriately and avoid unnecessary biopsies and procedures for patients is a really important component of lung cancer screening. Potentially the embracing of digital health and telehealth that we've seen as a result of the COVID-19 epidemic will help translate to telescreening programs, and also I think using machine learning and different computer-generated algorithms to enhance provider assessment of these scans is also an exciting area. Better blood-based biomarkers for early detection and for distinguishing lung cancer nodules from benign nodules is also an area of great need. But in general, in 2020, I feel like screening has taken a huge step forward thanks to the Nelson study and the enhanced recommendations from USPSTF. So please go get screened. If you or your loved one qualifies, you can save someone's life. Thank you.